Everything was going okay.
The number, and I'll get somebody to give you a
You're
call
welcome.
back.
Have a good afternoon. Bye.
All righty. When you're ready, you can get going, and maybe just remind people to turn their mics off. I
was just about to say, thanks, Taylor.
Yeah.
Awesome to be presenting here to everyone. Just as a reminder, if you could please turn your mics off.
I think we do have adults come here for vaccination, but I'm not.
Robert,
don't take my word for it. I'll get someone to call you back.
Disable mic.
Thank you. Sorry about that. Bye.
And Stuart, I might just disable your mic as well. Perfect. So hi, everyone. Great to be here with you. My name's Dr. Kevin Wernli. I'm a physiotherapist by trade. I still work clinically 1 day a week. I also did my PhD with a very esteemed group of researchers down here in Perth at Curtin University, Professor Peter O'Sullivan, Peter Cantan-Smith and Amity Campbell, all about how movement and posture relate to back pain. And that's kind of the topic of today's kind of webinar. I've been lucky enough to kind of present this around WA and Australia in various shapes and forms. So hopefully it can be a bit of a refresher or even just some new content for you. And there's loads of resources in there. We're going to try and make it as interactive as possible so that we maximise learning and retention strategies as much as possible. You guys can unmute yourself, as you found out earlier in the webinar. So feel free to unmute yourself and ask questions throughout the presentation. I have no issues with that. I will try to make it interactive and with a few quizzes and things like that. So I want to try and maximise this for you, but I appreciate you. Some of you might be dropping in and out with various lunchtime things and so on and so forth. So I'm going to start sharing my screen and then we will get underway. But like I said, feel free to ask questions as we go. So I'm presenting this from Wadjuk country down here in Perth. As I mentioned, physiotherapist by trade. I still work clinically 1 day a week, but I also help run Matilda, which is a digital prehab and rehab platform for endometriosis. So really keen in involving technology to make care more equitable and accessible. We're just up in Broome actually doing some events up there. As I said, respectfully acknowledge the Wadjuk Noongar people, the traditionals of the land and the waters where Perth is located. I've been lucky enough to travel around and present this kind of talk to a variety of different clinicians and the public. And you'll see I do some questionnaires and surveys which are validated measures for people's back pain beliefs. So we can compare your results to the rest of the people that I've presented this with. So your postcode is sadly a big determinant of your health, and pain, as with most health conditions, disproportionately affects people in rural and remote areas. You guys don't, you're no strangers to that. And a big part of the motivation for me is to try and translate this contemporary knowledge. So certainly some key acknowledgements, the co-hosts of the podcast, which I'm going to share some snippets from today, the co-authors of the paper, which the podcast is kind of based on, and then also my PhD supervisors. We're going to start with some baseline measures. So please use this QR code or use this link directly. That'll take you to a back pain beliefs questionnaire. That's a validated questionnaire for your testing your skills. Or testing your knowledge about back pain. It also tests my teaching skills in some ways. So we've seen really large effect sizes of people's knowledge here. So I'm going to get you all to start completing that. And I'll give you a couple of minutes to complete that. We're also going to do this at the end of the presentation just to see the differences that we have in your knowledge. So I'm going to stop sharing and so I can view my other screen so that I can see people's responses coming through. Actually, I'll keep that up just for a little while so you can use the QR code. This is all about trying to make it interactive and engaging. And I know there's lots of physios, there's a few GPs, there's OTs in the call, Taylor was sharing. So if you're anything like the physios that I know, you'll be quite a competitive bunch. So you can test your knowledge against various crew in Broome, Kununurra, I've done this event, Geraldton Exmouth down in Busselton. They're the main ones in WA. So we'll stop sharing and just make sure that that's all coming through. And then we'll start off with a little bit of a quiz as well. Just give you a few more moments while you complete that. Yes, very nice. I can see we've got a bunch of people already completed it. Great. So let's head back to sharing the presentation. And we'll get stuck into it. So a little bit of background, pardon the pun, it is intentional, obviously. We know that back pain is the most disabling health condition on the planet in terms of years lived with disability. It's more costly than cancer and diabetes combined. And there's kind of this, I think, quite a pervasive and unhelpful belief that the back is easy to harm and hard to heal. And like I said, I think that's an unhelpful belief that overall the spine is more vulnerable than the rest of the body. I think that contributes to more overprotective and unhelpful behaviours, which limit healthy loading of the back as a structure, which also provides obviously the adaptation of the structures, but also allows people to build more confidence and resilience in their back. So a few caveats. This might challenge your beliefs a little bit. There's lots of info that's contrary to commonly held beliefs, but it is backed by science. Knowledge is evolving, so hopefully what we know now is different to what we knew 20 years ago, and what we know in another 20 years will be different to what we know now. And I would say that this talk refers more to chronic, sort of non-traumatic low back pain and less to acute pain from a traumatic injury. There is a little bit of overlap there. Lots of people can have sort of these recurrent or persistent pain experiences, even from very minor movements, and sometimes, 1/3 of people don't have a specific mechanism of injury. I wouldn't deem that as an acute traumatic injury type presentation, and then this talk definitely applies to those things as well. So this is based off the paper we published in the British Journal of Sports Medicine that Professor Peter O'Sullivan led. This is basically from approximately 90 people treated for low back pain as part of a training program for cognitive functional therapy, which was recently published in The Lancet. There were these common myths that kept coming up from patients and kept tripping them up and keeping them in a cycle of pain, disability, and depression. And we saw that lots of these people saw large transformations in their symptoms. So then these we made, Peter kind of wrote down, and we made the more common facts or closer to the truths that helped them move beyond their pain. And as I mentioned, that trial that they were training physiotherapists up for has been published in The Lancet, with the 3-year follow-up outcomes also being published in The Lancet Rheumatology just the other week. Again, showing large effect sizes and really sustained effect sizes as well. So we're sort of starting to see that more, I suppose, mind, body, or cognitively driven, psychologically informed approaches for the management of pain, where we're addressing beliefs, but also addressing movement patterns and lifestyle factors, seem to show some improvements in function. We also created an infographic. This was co-created with input from patient voices, and I think this is great as a patient handout. There's links to these at the end of the slideshow. We also created 2 videos. One is the main video, which is I got patients to present these facts. And yeah, people who had recovered and moved beyond their pain, and then also the stories behind the facts. So we spoke to 6 of them to share their stories around how they recovered. Again, there's links to these at the end. Then there's the podcast we created, a bit of a COVID project. Episode 4 and 5 talk about the origins of the back facts paper, and then episode 11 to 20 is the more detailed discussions with authors, leading researchers, surgeons, and patients and people with lived experience. So I'll share little snippets of those, and you're obviously welcome to listen to more of those episodes or listen to them all via Spotify or wherever you get your podcasts. So we're going to start with a bit of a quiz. Now we're going to see how this goes because I haven't got you in videos, but we do have access to the chat. So can I just get you to, I'll just open up the chat here. Put in the chat whether you think what the best posture for pain, best posture for pain is. A, hunched, B, neutral, and C, laid back, or D, unsure. We've got B, we've got C, B, 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 lots of Bs, neutral. Nice, lots of B, so majority B in that. And that's probably the most common belief out there. But when we look at the literature, we actually don't have strong evidence for that. in that any posture is particularly good for everyone. So I think this kind of speaks down to specificity. And, the example I often use with patients is generic advice is never really good for everyone. It's generic by nature, right? So if we were to say everyone needs to wear size 7 footwear, that's fantastic advice if you've got size 7 feet. But if you've got bigger or smaller or wider feet than that, then that's actually not helpful advice. So we've got to individualize this to patients. And what we find when people have got back pain, they tend to hold better, and I say better in quotation marks, what we as society think is better positions compared to those without back pain. And when they recover, they revert back towards more normalized, natural, relaxed, and often quite slouched positions as well. We saw that in my PhD. So yeah, posture and pain are not strongly linked. The best posture is person-specific and variable, and yeah, the best posture is your next posture. Okay, the next question. What percentage of pain-free individuals, so the asymptomatic, will have low back disc bulges or degeneration on an MRI? Who thinks A, 20 to 40%, they haven't got pain, they're unlikely to have pathology. B, 40 to 60%, C, 60 to 80%, and D, I don't know, but they sound scary. So we've got some C's in there, we've got some B's, C's, lots of variety, some A, some B. So the answer for this one, another B, thanks Kira. The answer for someone who doesn't like the sound of disc bulges and degeneration, yeah, I think it's true. Like the language we use in scans can be really frightening, particularly for patients as well. They'll go and Google this or ChatGPT this, and they can really freak themselves out. This was a great study that Brinjikji did in 2015. He also did a paper, another which I call the Forgotten Brinjikji paper from 2015. But this one specifically looked at people that didn't have back pain and found that between age 50 and 60, about 60% have got disc bulges and 80% have got disc degeneration, and they don't have any pain. So it's a really high level. And they did find there was, his Forgotten paper in 2015 looked at people with back pain and saw that they were more likely to have things like disc bulges, but not things like annular fissure, for example, in people under 50 years old, or spinal stenosis in people under 50 years old. But under 50 years old, these were more common in people with pain, but this study looked at people without pain and saw that they had really high prevalences. So I kind of view it as one part of the puzzle, one part of the picture, but it's not in itself the key. It can be for some people, but it's often just one part of the picture, and we've got to think about all the various things that can contribute to someone's experience of pain. This was the paper that looked at that, and we can see that there is a very high level of, this is for 50-year-olds, 80% have disc degeneration and 60% have disc bulges, and those things increase as we get older. All those numbers increase as we get older. And, I sometimes explain to patients that's kind of similar to, a 50-year-old's more likely to have balding or graying or wrinkles than a 20-year-old. But some 20-year-olds do have graying and balding and early signs of wrinkles. So there's kind of genetic factors associated there. There's lifestyle factors associated there. And these things increase as we get older, but they don't necessarily predict pain, and they don't predict function either. So the imaging question, we'll kind of get to this in some of the myths as well. Okay, for most, back pain is resting a good idea. Yes, for A. B, no. C, I don't know, but I like to rest. Let's pop it in. So no. A lot of people going no in the chat. So Professor Rochelle Bookbinder led a really good program saying, or sort of paper and campaign, public awareness campaign called "Don't Take Back Pain Lying Down," and yeah, that was quite a important paper in the Lancet in 2018. So yes. Back pain for most back pain, rest is not a good idea. Certainly a couple of days, if you've got an acute episode, it can be useful, but long term, not associated with improved function. Okay, a strong core. Is it important for improving back pain? If we've got people with back pain, is it important that we strengthen their core? Do we agree? Do we disagree? Are we unsure? A lot of people going B, disagreeing with that. Most people, everyone so far, some A's. Everyone so far is going in B. Some A's again. So the literature around this is quite a contentious issue, but the literature around this, and Mannion and Smith and Saraggiotto have done these sort of researches where they, or papers where they measure people's core function and see if that improves. And if that improves, is that related to their function improving? And the short answer is that it's not. So people improve with core exercises, but they also improve with a variety of different other exercises. But that improvement is unrelated to whether their core function actually improves. And Anne Mannion talks about this idea of like you're getting people to exercise and move, and they're starting to be able to do more things, so they build more confidence. And that maybe the mechanism there is that they're building more safety signals in their body with movements and feeling more, I suppose, secure and safe in their body, as opposed to actually strengthening their core. Sometimes the core can, people are really worried about their core and feel like their back's really fragile if they don't train their core. It's really good to have a strong core for functional movements and doing sit-ups and getting out of bed and things like that. But it's not really related to back pain, neither in recovery or even the prediction of back pain. The whole idea came, and we talk about this in episode 17, the idea of core strength being important for back pain came out of a study on about 30 university students in New Zealand, mainly males, that showed there was a very minute, like millisecond reduction or slowness of the transverse abdominis firing in people with back pain when they lifted their arm. And then the world kind of exploded from, oh, that must be the cause of back pain. And we really got into training the core, and now it's quite ubiquitous out there, despite there not being super strong evidence behind it. So there are many reasons why back pain improves. Feeling confident and strong is important, and trusting your back's important, but strengthening your core is not strongly related to improvements, surprisingly. All right, some lifting stuff. How should you lift a 10-kilo box? Keep your back straight, bend your knees and brace your core. Get someone or something else to do it. Round your back or sit on the fence and we're not too sure. What do we think for that one? D, unsure. A, straight back, bend your knees, brace your core. D, unsure. D, A. So mainly focusing between D and A. Yep, I think I will stick with a lot of A's in that as well. That's the traditional manual handling advice. But surprisingly, when we investigate this in the literature, we don't really have strong evidence for that. And the answer for this one is we're unsure. We don't really have strong evidence. So Nick Saraceni did a systematic review in 2019 that looked at the mechanics of people with and without back pain lifting. And there wasn't really much difference, and there's only research up to 12 kilograms, and there's one study that Tim Mitchell did that looked at this longitudinally to try and see did people lift differently if they're about to develop back pain, and he couldn't find a relationship there. There's been research, replicated research in a variety of different high quality journals where they give people a manual handling intervention and don't give people a manual handling intervention and see what happens. Is there a reduction in injuries? And there's no reduction in injuries or pain. So surprisingly, despite again how ubiquitous this relationship is, or this belief is, there's not strong evidence to support it. And David Nolan, interestingly enough, did some research where he did kind of questionnaires similar to the ones that you guys have filled out earlier today, before and after manual handling training, and their back pain beliefs were worse after manual handling training. They become more frightened of their back. And I think that can potentially, in the right person, or I suppose in the wrong person, lead to unhelpful patterns, avoidance patterns, excessive protective patterns, moving in a way that doesn't feel natural and strong for that individual. And then that can paradoxically result in not recovering from episodes of back pain. So our research is quite inconclusive in that. Okay, so we're going to now talk through and show these little snippets of, like I said, feel free to ask any questions or unmute yourself or post questions in the chat. I'll keep an eye on that as well, and Taylor's going to keep an eye on it too. But let's start going into some of the myths and facts of back pain. So the first one is that back pain is usually a serious medical condition. So Joletta Belton presented this one. She's a pain patient advocate. She works with the Journal of Orthopaedic Sports and Physical Therapy, JOSPT, as well as writing blogs and things like that. She was a patient of Pete's at the San Diego Pain Summit a few years ago and had hip pain that wouldn't go away. And she has learned, does a lot of great blogging and is a real great advocate for, I suppose, multidisciplinary care for pain. So we'll play this quick video.
Persistent back pain can be scary, but it's rarely dangerous.
Persistent back pain can be distressing and disabling, but it's rarely life-threatening, and you're very unlikely to end up in a wheelchair.
So this episode, I spoke to Pete and kind of asked him the question of, like, if someone's, they kind of get that, okay, it's not a serious condition, but what should they do? And this is what he said.
So I'd be going, look, if you're really worried about it, first rule of thumb is, have you had significant injury? That's not bending over picking up a sock. It's like a trauma, big fall, sudden loading event.
Oops, that stopped playing.
Could there be a fracture? Or maybe that you've got I can think of people who are osteoporotic where it's not a major event, but they've had acute back pain.
Yeah.
But in saying that, those people get better as well because the bones heal. Bones are wonderful structures. They're bloody painful, but they get better, and they get better really well. So number one rule of thumb is that if you're worried about something serious, have you got a fever? Have you had cancer before? Those are the kinds of questions to ask. You got pain at night that is, non-remitting, and you got a fever, then, or you've got rapid weight loss and you've got other, ill health that goes with it.
Yeah.
Go and see your doctor.
Yeah.
And there's no harm in getting checked. Okay. Now that may involve a scan. And if you get a scan, just be aware that as you get older, the more stuff will show up on that scan. So be reassured that you will have stuff on the scan. So for me, I would expect stuff on the scan. I had an MRI scan for a different reason, and I've got disc bulges and, narrowing and God knows what in my spine, but it's nowhere near where I might get sore. So there are a lot of things that are normal. Scans are very sensitive. So Be reassured again. If it's an acute pain and there's been like a sprain, then be reassured it will get better within a couple of weeks.
Yeah.
But do the right thing. Keep moving, keep active, use a heat pack, gently move, relax, get mobility back into your spine, keep working. Don't lie, don't rest, don't overprotect, and have a positive mindset. It will get better. If it doesn't get better, seek care. But seek care from someone who's going to provide you an evidence-based approach to managing your pain.
Yeah.
And that usually is, don't let someone take over your care. Make you the...
I was going to finish there by saying, make you the centre of the care, and I suppose that speaks to shared decision making and person-centred care. So we're working together with our patients to motivate them to get better. The second common myth that came up was like, I'm just getting back pain because I'm getting older. And there is a bit of an increase as sort of between 30s and 50s of disabling back pain, but actually drops off after that. And so I think that's a common worry for people. Is like, if I'm like this when I'm 20 or 30, what am I going to be like when I'm 40 or 50? But the evidence doesn't really support that. So I got Chris, is one of the participants in my PhD, to talk about this belief, I suppose, unhelpful belief, and then share the fact as well.
Getting older is not a cause of back.
Although it's a widespread belief and concern that getting older causes or worsens back pain, research does not support this, and evidence-based treatments can help at any age.
So for this one,
Getting
we
old.
spoke to Jan, who is, I think, was 73 years young at the time that we recorded this. And she'd had back pain for a long period of time, and made a really nice recovery.
So if you look back 3 years ago, say,
Yes.
and you look at to where you are now,
Yes.
are you better or worse?
Oh, I'm better than when I was 3
Okay,
years
so you're
ago.
3 years older,
Yes.
you're closer to 80 and you feel better.
Yes. Much.
So that goes against the idea that you're going to get worse with age.
Yes.
So why are you better? What's made you better
what's made me better?
even though you're 3 years closer to 80? What's different? Because your body's 3 years older.
Okay. What's different is I've given myself permission to give some people the flick. Look, my social network is very important to me. But being a compassionate person as I am, I found that other people wanted to dump all their stuff onto me.
And so I think when you're recording podcasts, you never really know where they can go, particularly with patients. And so I was not expecting that answer from Jan, but I think it speaks to the biopsychosocial aspect of pain. And she was obviously taking on other people's stresses, and her body was holding tension as part of that. She wasn't looking after herself. And that aspect of, self-care, not being selfish, I think is really important for that. So yeah, her body's older, but she feels better. The next fact is that it's always related to tissue damage. And the kind of the slogan we used in the podcast was, remember to ask, is there more to pain than damage? Because I think this is the most common belief that stops people from improving. Absolutely, back pain, like rolling your ankle, can be related to tissue damage if there's been sort of a loading event or an event that exceeds the current tissue's capacity, which if people have been avoiding things for a long period of time can be really low. But very rarely is persistent back pain that lasts, more than the 3 months, related to tissue damage. It's often related to a variety of different factors. We got Pete Moore to talk about this. He's a pain patient advocate as well.
Persistent back pain is rarely associated with any serious tissue damage.
Backs are strong. If you have had an injury, tissue healing occurs within 3 months. So if pain persists past this time, it usually means there are other contributing factors. A lot of back pain begins with no injury or with simple everyday movement. These occasions may have contributions from stress, tension, fatigue, inactivity, or unaccustomed activity, which can make the back sensitive to movement and loading.
So for this episode, we got Professor Rochelle Bookbinder. She was the lead author of the Lancet Low Back Pain series in 2018. A really highly regarded researcher in the back pain space. She's a rheumatologist out of Melbourne.
When you talk about persisting symptoms, I try and explain that it's got much more to do with other factors, not the actual pathology that you might see on an image.
Yeah.
It's much more to do with psychosocial factors.
Yeah.
And that often turns on a light bulb, I think.
Yeah.
When you talk about what predicts, what are risk factors and what might reduce your risk, and you talk about things like smoking and obesity and catastrophization and fear and beliefs, that then starts a conversation about, maybe if I think about those things, less about the pathology, that might be a way through.
So I think that speaks to, again, this idea that there's a variety of different factors that can contribute to pain, and pathology can be one of those things that we need to be mindful of and obviously rule out. That's our first job, is to rule out red flags. But often for persistent type cases, it's less to do with those things and more to do with capacity, movement patterns, excessive protective patterns, other life stresses, variety of different things that sensitize the nervous system or contribute to more threat and danger signals in the nervous system. So number 4 is that you always need a scan to detect the cause of low back pain. I think it's about 80% of patients in primary care want a scan or think they need a scan to help understand the cause of back pain. And as we sort of shared a little bit in that pre-quiz, that can be a bit of a trap for some people. There's loads of red herrings, which if they're not explained clearly and taken into context with the clinical picture, can be quite problematic. So, I mean, I've got a number of examples, but one that particularly comes to mind was a few weeks ago. They had pain down their right side of their leg. They had a disc bulge. We had a look at the scan. We saw that the actual disc bulge was on the left side of their back and their pain was down the right side. So that really hadn't really been explained to them well. So I think correlating people's symptoms with the location of the pain. Another one, sort of talked about how they had back pain, it's actually more mid-thoracic back pain. And they were worried about their disc bulge, and their disc bulge was way further down, much lower down, sort of your classic L5S1 pathology. And that clearly doesn't relate to that person's pain, but that person believed that it did and were very protective in their movement patterns as a result of that. For this one, we got Adrian to talk about this. Now, he's quite an interesting case in that he had back pain. He's kind of in the military in the UK, And he was kind of a bit fed up with his back pain, as lots of people are, and was like, well, I'm just going to start exercising again, and I'm curious to see what happens with this. He started exercising, moving, doing things like what you're about to see, we called a Jefferson curl, and his pain didn't really improve, but so he got another scan, and his disc bulge had improved, but his pain hadn't. So this again speaks to the lack of relationship between pathology and symptoms.
It's rarely show the course of back pain.
Scans are important, but only for a minority of people. Lots of scary sounding things can be reported on scans, such as disc bulges, degeneration, protrusions, arthritis, and so on. Unfortunately, the reports don't say that these findings are very common in people without back pain, and that they don't predict how much pain you feel or how disabled you are. Scans also often change, with most disc prolapses shrinking over time.
So a couple of important facts there, the commonality or how common these findings are in people with asymptomatic pain. And then also the garden changes over time. So we know that, up to 83% of disc herniations resorb by themselves, and that their degree of resorption is actually unrelated to whether someone's symptoms improve as well, which I think is really, really interesting. For this one, we spoke to Joe. He's a sort of a patient voice. This is one of the most common or sort of popular episodes, and Joe's really articulate. He's done a number of different media pieces and things like that, and he's going really well now. I saw him the other day, actually. He's wing foiling, he's diving, he's got a kid, really active, and I think we can learn a lot from his story.
I guess the biggest thing for me was knowing that pain wasn't coming from damage, and that the scan wasn't telling the truth. I mean, there's so many people out there that would have the exact same scan as me that wouldn't even know.
So again, this kind of speaks to a couple of important things. Like I said, there's that table that we showed in the quiz. Another really interesting study that Roger Herzog did in 2017 actually, where he had one patient with back and leg pain, and he got her to go to 10 different MRI centers in the US within a space of, I think, 2 weeks, or 3 week period, sorry. And there was 49 different findings. 16 were unique and only found in one of the reports. And there was not a single finding that was reported across all 10 MRI reports. And then each radiologist averaged 12 errors compared to the kind of consultant spinal surgeon and radiologist that kind of authored the paper. So I guess what this means is that don't just rely on the scan. It's only part of the bigger picture. We want to treat the patient, not the scan, and correlate that with clinical symptoms. If I've got great rapport with a patient, I might say, look, if you're really worried about your disc bulge, maybe just go down the road, get another scan, and you might not have that disc bulge. But that has to be managed sensitively with people, of course. So number 5 is that pain related to exercise and movements always a warning that harm is being done to the spine and a signal to stop or modify the activity.
Pain with exercise and movement doesn't mean you're doing harm.
When pain persists, it is common that the spine and surrounding muscles become really sensitive to touch and with movement. Importantly, the pain you feel during movement and activities reflects how sensitive your structures are, not how damaged you are. So it's safe and normal to feel some pain when you start to move and exercise. This usually settles down with time as you get more active. In fact, exercise and movement are one of the most effective ways to treat back pain, and having a health professional coach you through the process can be helpful.
Before, if I moved and there was pain, I would immediately stop because I was listening to my body, and the pain meant stop whatever you're doing. That's not the right thing to do. The new movement was, oh, the pain's still there, but that's okay. You can still move. And I kept exercising or walking, mostly walking when I was in severe pain.
So Megan sort of talked about her mindset shift around pain automatically meaning danger or stop. And I think we're caring people, like we don't want our patients to have pain. So quite quick to say, oh, if it's sore, don't do it. But often we've got to test, is it sore because of, that person is a warranted soreness? Or if we modify a few things around that, can we change the way that they're moving? Can we change a few things, and does that influence their pain? And if it does, the problem's not that the pathology is causing pain. The problem is the way that that person's moving around that structure or their belief that's kind of triggering the pain more, and modifying things and not being super avoidant of things in the long term, I think, is a much better strategy for helping people. Megan also talked about this idea that pain is in the brain, which we'll sort of talk about here.
Understood as well that all pain starts in your brain. I was able to tell my brain to cut it out, just stop, and I'd be able to calm myself down and go, you're not actually in pain, you're not hurting yourself. This might feel uncomfortable, this might feel painful, but it's not hurting you, so keep doing it.
That's quite a hard message to swallow, that your brain itself is trying to protect you because of a memory of something, but that protection is now not needed.
It is, but I think it is a very, it shows my age. You know, when I was a child, you were told if you had a brain injury or if you broke something in your brain, it was never, you would never be able to fix it. That was it. Right. That was your luck and life. Yeah, but now we know that a brain repairs itself. Yeah. Right. So we know the brain is
plastic.
Plastic, exactly. And you can teach.
And she was going to finish there by saying you can teach strategies to help improve that. And I think what she's speaking to is obviously neuroplasticity and bioplasticity. And I'm not a huge fan of pain-splaining or pain education in isolation. I think education around pain or anything really is a dish best served experientially, which is kind of ironic given that I'm kind of providing a lecture on this. But obviously we're trying to make it as engaging as possible. But I think this speaks to, the body's ability to change itself, and neuroplasticity is one sort of term in the umbrella term of bioplasticity. And Lorimer Moseley talks about this idea of bioplasticity is what got you into this mess of more persistent type chronic pain. And bioplasticity is what can get you out of this mess, and kind of shifting that, that can be a negative spiral that people go on. But by definition, if there's stuff that contributes to a negative spiral, then all those, if we can kind of reverse engineer those things, we can shift that. And yes, it takes a lot of inertia to start spinning the other way. But once we start getting going, we can see that as a positive spiral as well. Number 6 is probably the most common belief, and what led to me doing my PhD, or was one of the core things that led to me doing my PhD, and that back pain is caused by poor posture when sitting, standing and lifting. And this is another patient from my PhD study who really held this belief quite strong, and her shift was kind of a whole schema shift around the belief or the unhelpful belief around posture causing pain.
Back pain is not caused by poor posture.
How we sit, stand and bend has not been shown to cause back pain, even though these activities may be painful. A variety of postures are healthy for the back, and it's safe to relax during everyday tasks such as sitting, bending and lifting with a round back. In fact, it can be more efficient.
So for this one, we actually had 2 episodes for this because I think it's such a strong belief. The first one was with the co-authors of this paper in the JOSPT, the 7 Surprising Facts of Posture. Again, the resources for this are in the resource page at the end of this, which you can go through. What you'll get sent to at the end of the lecture.
Go through the.
I also wanted to just highlight this second aspect. So we got Joe back for another episode. This was all around posture and pain, and we also spoke with Dr. Nick Saraceni, who did his PhD in lifting and back pain.
In hindsight, yeah. Well, I think that to be honest, I think that having that stereotypical good posture and keeping that upright spine all the time, I think just stiffened everything up. I think
do you see those prevalent beliefs as unhelpful?
Oh yeah, absolutely. Yeah. Absolutely. It's massively unhelpful. I mean, we're conditioned from such a young age to think that our backs are fragile and that we've got to protect them by keeping them straight, especially when lifting or loading. And I mean, it's unfortunately that's. I mean, it's just weird. I sort of almost, I still look at that box and go down to, and I'm like, what the hell am I doing? It's like, that it's absolutely unhelpful.
Okay, number 7, this is potentially, well, a lot of them can be quite controversial, but this is the idea of around the weak core being the cause of back pain, and having a strong core protects against future back pain. Anthony, again, was one of the PhD participants in my PhD, and he had this really strong belief around, I must stay neutral at all times. Interestingly enough, he was quite strong, so he was able to deadlift 140, 150 kilos. But he was terrified. He would only do that in very neutral positions of his spine, and he was terrified of rounding his back, and things like, he's got his little dog there in the background. That would really frighten him because it was sort of uncontrollable, and so picking him up, if his wife was to jump on his back unsuspectingly, these sorts of things really worried him. So it felt really safe in neutral, but terrified of anything outside of neutral. And his quotes are sort of etched in my brain around, if I bend forwards, my belief is that my disc is going to bulge out and shoot someone behind me, hit the surgeon or hit the doctor, in the room behind me. And so I think these beliefs are really powerful and potent for some people. And his strongest fear was, I've got to brace my core. And the most scariest thing for him was if he was to round his back relaxed and then lift. And the physio got him to do that in the second session, and he was fine with that. And that really unlocked a whole bunch of things. It was sort of like, oh, if I can do that and be fine, and obviously it takes a very skilled and brave clinician to guide someone through that, and you've got to obviously rule out other red flags and things like that. But if he can do that without pain, then that kind of automatically unlocked all the other stuff that was less scary than that for him. If he could do that, then he could kind of do anything. And that was a big turning point. That the paper that we published in the European Journal of Pain called "From Protection to Non-Protection." There's some really good quotes from him in that. That's open access.
Back pain is not caused by a weak core.
Weak core muscles do not cause back pain. In fact, people with back pain often tense their core muscles and suck their belly in during activities as a protective response. This is like clenching your fist after you've sprained your wrist. Being strong is important when you need the muscles to switch on, but being tense all the time isn't helpful. Learning to relax the core muscles during everyday tasks can be helpful. To read the full.
So this one, we spoke to Professor Peter O'Sullivan himself. He's got his own lived experience of disabling back pain. And this episode, again, I think this is the one where I've talked about. We kind of explored the evolution of the belief that it's really important to have core stability for back pain, although that is kind of, hasn't been supported with more recent literature.
I looked at myself in the mirror and I thought, you know what, I am holding myself awkwardly. I was holding myself very stiff and rigid and contracted. And I was really fortunate one day that someone said to me, why are you holding yourself so awkwardly? And I kind of stopped and I looked in the mirror and I kind of gave myself permission to just stop doing it. And almost at that point, I became not just aware of my pain, but I became aware of all this protective guarding that I was doing for myself. So I kind of, over a period of time, it just unraveled, where I just broke those rules of like train myself to relax my back and not brace my core, and it just taught myself back to being normal again. And as that happened, the whole pain system of obviously my concern, as the pain reduced, my levels of concern and distress reduced, and my capacity to function improved, and so did my sleep and a whole lot of things. So it just unraveled basically that whole process.
So I think that kind of speaks to, this sort of, it's not just about shifting movement or posture or one factor. It's kind of this whole schema shift of a variety of different factors, improving and sort of at that positive upward spiral instead of the negative downward spiral. We've got 3 more facts to get through, then we've got some time for Q&A at the end. So this is the most, another common factor, that the more you move, the more you load your back, it results in wear and tear and tissue damage. I think this is true, a true belief, a common belief, I should say, in osteoarthritis as well. And we're moving more towards a wear and repair type model or language, as opposed to just wear and tear.
Backs do not wear out with everyday loading and bending.
The same way lifting weights makes muscles stronger, Moving and loading make the back stronger and healthier. So activities like running, twisting, bending, and lifting are safe if you start gradually and practice regularly. To read the full.
So this one we spoke to Dr. JP Canero.
And the fact is they're actually using your body repetitively in a healthy manner without protection is actually a better way for your body. Similar to muscles that get stronger as you use them. Muscles that become less stiff as you use them and you stretch them. Other body parts are like that. The knee joints, the tendons, the discs, the shoulder, the neck. So there's more and more evidence to demonstrate that.
Okay, number 9 is around flare-ups. I think if anyone, many of you probably manage these sorts of conditions, and patients are often terrified of flare-ups, naturally so, right? It feels like they're going backwards. Flare-ups are also a really useful, or can be a useful experience around learning as well. So if someone gets through them and they are able to manage, then I think that can be a really positive experience for people, positive learning experience if they're managed well through it. Jamie talked about his flare-ups in this episode, and the myth is that flare-ups mean that you've caused more damage and you require rest. And again, while that can be true, it's usually not, and the literature suggests other factors are more related to flare-ups.
Pain flares don't mean you're damaging yourself.
While pain flare-ups can be very painful and scary, they are not usually related to tissue damage. The common triggers are things like poor sleep, stress, tension, worries, low mood, inactivity, or unaccustomed activity. Controlling these factors can help prevent exacerbations. And if you do have a pain flare-up, instead of treating it like an injury, try to stay calm, relax, and keep moving. To read the full.
So yeah, I suppose that kind of literature came from a prospective study where they tracked people's a variety of different factors and tried to predict what was preceded a pain flare, and it was never really changes in physical activity. There was some literature around like prolonged standing and more sedentary behaviours sort of in the lead up to predicted a flare, but usually not heavy lifting or other activities, and also like more emotional stresses were highly associated with flares over the next couple of days as well.
Did you think that was it? You were sorted?
Yeah.
Right.
Yeah.
So how did you feel
Yeah.
when the pain came back?
Yeah, it was scary.
Yeah.
Scary because I found myself slipping back into the old ways so quickly.
So I think, that the memory of pain and the really unpleasant experiences and threatening experiences that are associated with that can trigger this almost relapse, not just into more protective movement patterns or avoidant movement patterns, but also the flooding back of the distress, the beliefs and the worries.
I think we've got a population that's conditioned to think if it hurts, there's something damaged, you need to protect it, you need to stop, you need to rest it.
Yeah.
And it's really hard when that's your mindset.
Yeah.
To go against the grain.
Yeah. Well, I mean, I almost did it again.
Right.
So yeah, it is.
Huh. And have you had another event since?
No. I've twinged my back.
Yeah.
And that, but it's like, yeah, okay, no thing. So I continue what I do, but not stupid. I won't whack another 10 kilos on the bar or anything like that. I'll just, okay, that's a bit sore. I'll just do something else, and yeah. But if I ever do get a twinge in my back, then I'll do squats and stuff like that. Not with weight or anything, but
so you
deep
do
squats.
exercise
Exercise that area for sure.
Yeah. So move the painful bit.
Yeah.
In a gentle, repetitive way.
Yeah. Yeah. And you can feel it draw out and it feels good. It's good. It's a good thing.
Yeah. Okay. So.
And then a final fact is treatments such as strong medications, injections and surgery are effective and necessary to treat low back pain. This story is, people probably shouldn't, or I feel like podcast hosts shouldn't have favourite podcast episodes like you shouldn't have favourite children. But if I was to be, put on the spot and say which one's my favourite episode, I would say this one, episode 20, which corresponds with episode 10, fact number 10, sorry. We spoke to Professor Ian Harris. We also he was on the ABC with this patient that you're about to hear from, Stephen. Stephen was again one of the participants in my PhD PhD. We recruited him through an ABC interview that Pete was on the radio and he called up as a patient. So ABC was kind enough to let us use the audio from his phone call, as well as the audio and video from his after he went through the journey. And he was on workers' comp. He had a spinal fusion. He had 2 microdiscectomies. He was on opioids and had quite the journey to kind of improve. But we were kind enough to get ABC was kind enough to give us the audio from the sort of follow-up segment that he did with Professor Ian Harris. And once he recovered, he's now kind of working out in the country, playing hockey. Yeah, really a nice success story.
Injection, surgery, and strong drugs are usually not a cure.
Spine injections, surgery, and strong drugs like opioids usually aren't very effective for persistent back pain in the long term. They come with risks and can have unhelpful side effects. So finding low-risk ways to put you in control of your pain is the key. To read the
So again, we spoke to, like I mentioned, Professor Ian Harris, who wrote the book, The Ultimate Placebo. He since wrote another book called Hippocrates with Rochelle Bookbinder. And who you heard from earlier on, is an orthopedic surgeon from Sydney.
Most people in the public, if you were to tell them that the surgery they were proposing to have, or this operation or that operation doesn't actually work, it doesn't sit right. It doesn't make any sense. Like, what? Yeah. Why would you do it if it didn't work? So I'm trying to make the public a little bit more skeptical, meaning not cynical, but meaning scientific and more objective, and not just assuming that things work because people do them. So the evidence for what we do as surgeons for musculoskeletal pain is very bad.
So you can imagine how popular he is amongst his surgeon colleagues. But I think, again, to his credit, he was sort of wanted to do research on this, and he's done a lot of surgery-controlled or sham surgery trials as well. He talks a little bit about workers' comp, but just in the interest of time,
Tells us a little bit about the complexity
of that. Because I'd love to sort of summarise and then give some space for questions and a bit of a discussion as well. I often find that leads to some good learning as well. So a couple of important things to remember. Pain is real 100% of the time. It's 100% real 100% of the time. But there's lots of different biopsychosocial factors that contribute to a person's experience of pain. And they're all the things that we need to be mindful of when the person sits in our treatment rooms. In other words, pain happens as a result of many interacting multidimensional factors. Damage and injury may be one factor, but when we're talking about persistent pain, it's rarely a key driver. And that's even if you can see it on a scan or a patient has been told it's a key driver. As we saw, these findings are really common in people without pain, and they don't predict future pain or disability or function. It can be helpful to reframe structures as sensitized or irritated, and that they need love and loading. And sometimes this may be despite or through pain in a very kind and mindful way. So while your structures may be sensitized at the moment, they're unlikely to be sensitized to damage. They're sensitized to pain, yes, because our pain system is highly sensitized, but they're unlikely to be sensitized to damage and certainly not immune to getting healthier and stronger. It's not often an easy journey. For some people it is, but with a good coach, I think people can get back to living, and your system is a beautiful bioplastic ecosystem up until the day you die. So we want to encourage things that are fun, healthy, and bring people joy, and not to give up. There's a bunch of references, and I'd like to now to retake the quiz. So this is the link is a slightly different one. Same quiz, bit of an option for some feedback at the end there as well. But once you complete that quiz, you'll be taken to the resource page where it's got the videos, the podcast. There's another great resource, which would be remiss of me to mention at the moment. It's kind of come out quite recently that Professor Peter O'Sullivan, Peter Kent, Dr. JP Canero have been involved in or are leading, called Evolve. That's with 2 O's. The Evolve Pain Care Academy, which is all about an online platform to help upskill clinicians in treating with cognitive functional therapy, which is the intervention that was used in my PhD and the one that has undergone rigorous testing through randomized controlled trials and published in The Lancet. So I'll leave this up a little bit longer and then I will open the floor to some questions for the last 5 or 6 minutes, and I might once this webinar is finished, I'll calculate the differences, and I'll share that back with Taylor, and she can share it in an email what the differences in average back pain beliefs are. So thank you for your attention and giving up your time on this Wednesday lunchtime. I do consult, like I said, clinically 1 day a week in Lathlane at the West Coast Eagles training facility. I also do consult online as well. So I've got patients all over. And yeah, I think I suppose my model of care is more around a coaching approach rather than a fixing approach, and helping people understand various things and yeah, help them get back to living. So I'm going to stop sharing there while you guys finish the quizzes, and like I said, open the floor to any questions. I'll see if I can start calculating some of these changes, whether there's been any changes in your questions or your responses. Does anyone have any questions? Feel free to unmute yourself.
I don't have a question, but I thought your myth 8 was quite interesting. It made me think of my husband was a decky on a cray boat for 10 years, lifting 120 pots a day by himself.
Yep.
And like that's fairly intensive lifting on a boat that's like doing it on a trampoline.
Yeah.
And he has no back pain. He never had a back injury. So I just sort of thought, that it's proof of what myth 8,
Totally, yeah. The more you load your back, the worse it's going to get. Yeah. And I think the easiest example to use with patients is like, and often ask them, I think often people don't argue with their own data. So rather than telling them, I often ask them, but I'll ask them, what happens if you go to the gym and start doing bicep curls? Be like, oh yeah, I get stronger. Oh yeah, what happens if you progressively start running or, loading your legs? Oh, there's bone mineral density that increases. And the back is living, breathing structures, tissues. And the more that you load them in a graduated, safe and appropriate, non-protective way, the more they respond. Yes, cartilage, which is what makes up discs, is a little bit slower to respond than, say, nerves and muscles, but it still does respond positively. There's been great literature around, marathon runners have, after their marathon training, have healthier knees and healthier looking spines, more hydrated spines than they did before marathon running. Or cyclists having stronger and healthier discs and more hydrated discs than non-cyclists. Now, there's a variety of different factors there, large systemic factors. Maybe they eat better as well if they're exercising more, they sleep better. A variety of different factors. Sleep's really important for new tissues, things like that. So that I think is really interesting. Another study that Batty did, which was a twin study in '93, that looked at twins and only found twins that had very different careers. They were genetically obviously the same because they're twins, but they had very different careers. One was more office-based and one was more landscaping. And their hypothesis, or it was kind of more manual labor, their hypothesis was that the more that the twin that would be more manual in their job would have more disc degeneration and a worse looking spine, but there wasn't a strong relationship there. And it was actually, a trend towards the more physically active or laborious jobs that had healthier looking spines. Any other questions?
Is there any movement towards, and I feel like a few years ago I heard that maybe they were putting like those common, like, hey, the scans really show the cause of back pain, that then at the bottom there'd sort of be what normal is on the scan?
Yeah, there has been some literature that shows that really reduces the perception of threat in those people. I have started to see it in some scans. I think it's a bit variable and it depends on the radiologist. But I have started to see that, these findings can be really common and normal in people without symptoms, and please discuss these with your doctor. And I think overall there's a bit more of we have to remember that radiologists, they're sitting often in a dark room and they're just pumping through MRIs, reporting on things, and their job's to report on things. And from a medico-legal perspective, they're in trouble if they miss stuff. So they're always, and MRIs are fantastic technology. They're so important for a variety of different things, including back pain when it's indicated. But we have to remember the kind of the constraints that they're in. I think that's improving with AI. Still obviously having a human in the loop, but there is a little bit of a movement to it. I don't think it's standard across the different radiology providers yet. Good question though, Liza. Any other questions?
There is a couple in the chat if you want to view the
Oh, yep.
chat.
Perfect. Let's have a look at the chat. Does manual handling training before back pain help to reduce? Yeah, so really interesting question, Portia. And the short answer is no. The literature shows that, and there's been a number of systematic reviews. Van Dien, I think, is the most published author in that space, where they compare manual handling and sort of manual handling training and interventions compared to no manual handling interventions. The same goes for ergonomics as well. And then they track, is there any difference in incidence of back pain? And there's no difference to that. And I think that speaks to the multidimensionality of pain. And yeah, like loads of different factors contribute to pain, and making sure that we first check if has there been any like big spikes in load that may predict this back pain or may contribute to this back pain, where load has exceeded capacity. If yes, then we need to treat it like any other sort of overload type presentation. Let things calm down, then build things gradually back up. But often people have no mechanism. I think it's one third of people would have no recollection of an incident, a mechanical or overload incident. And then you might start asking questions like, give me some context around what was happening in your life at the time this started. We know things like sleep influence your body's ability to recover from minor triggers. Often stressful life events are associated with these sorts of things. And that often people, need to have the tissue box often handy there. But people often be like, oh yeah, actually that was a really stressful time, or I had this X, Y, and Z going on and wasn't looking after myself, or various different things. So yeah, there's no real relationship between, which is surprising given the industry. I think there's a shift towards kind of this fit for work type model, and helping coaching people to lift in a variety of different ways and be, have their kind of capacity match their requirements for their work. That seems to be important. But yeah, no real relationship between safe lifting training or ergonomic training and reductions in incidents on average. And then Kristen, your question on thoughts on manual handling training for nursing and hospital staff. Yeah, I think I see so many nurses that's just come in with, nurses back, and there's firefighters back, and I'm sure there's a variety of different manual handling occupation here. And I think I think it precipitates or perpetuates unhelpful beliefs. And I think what we should be doing is encouraging, obviously the hierarchy of risk control is eliminate the risk altogether. So that's where tools can be really useful to, hoists and things like that. That's not always available. But I think training people to be fit for their task, fit for demand, and building their capacity to match their requirements is a really important thing. But also educating nurses on the variety of different, and everyone on the variety of different factors that contribute to pain, and particularly contribute to pain not getting better, which is probably more important, because it is, 80% of us will have an episode of back pain across our life. It's pretty unlikely that that's going to be, a long-term problem. Most people will recover, and between 20 to 30% of people result in having persistent pain. So that's not the majority, very far from it. So most stuff happens to get better by itself. So I think manual handling training for the nursing and hospital staff should be centered around a fitness for capacity building model, fitness for work model, and consider the variety of different factors. And nurses are working long hours, high pressure, high stress, often shifts, influence of sleep, variety of different things. Janine Taylor, how would you hold a patient with radiculopathy type pain to allow resorption, assuming a scan has mild disc bulge with corresponding symptoms? Yep. Versus referring onwards for review if nil red flags, numbness, weakness. Yeah, so I guess the key thing there is there progression of radiculopathy type symptoms? So radiculopathy speaks more to pathology, obviously related to the nerve, and you have signs of paresthesia, power loss, and reflex loss. There's pain associated with that. It's kind of referred more to as radicular type pain. And that's often related to more of an inflammatory process around the nerve and around that area. How would we manage them? Look, I think it's person-specific and individual. We used to, avoid flexion for those people, but some people get really huge benefit from flexion. And when people go into flexion, often the annulus fibrosus can act as a bit of like a spring or a trampoline and help with the reduction of the disc back into the sort of the spinal or into the vertebral body, versus we used to think that flexion would mean the disc would bulge more. So I think it has to be person specific. How long would I hold on to them, which I suppose is more your question reading it again. Certainly probably no longer than 3 months. I think that the literature sort of suggests within 6 months, the vast majority of people would have seen an improvement. I think if we're really not seeing much improvement within 3 months, 12 weeks, that's when I'd be looking at referring. Or if someone have really high levels of pain and distress, I'd probably refer them earlier for potentially an injection or a second opinion. Obviously, that's not our decision to decide as physios, because getting rid of pain or reducing pain earlier does seem to be an important thing. Having said that, most of the literature for back-related leg pain, the pathway, the endpoint is very similar. The pathway to get there with more interventions being microdiscectomy, surgical or injections tends to be you have a nicer pathway there. Your pain reduces, your function increases sooner than a longer pathway to get to the same ending if it's more conservatively managed. So yeah, hope that answers your question, Janine. Any other questions? Cool. So thanks very much for your participation. I can have a little look at your beliefs around here. See if I can quickly calculate your scores and compare them. But yeah, feel free to keep asking questions if you've got them. Overall, your beliefs were pretty good to begin with. And then after, yeah, much better. So let's look at the average. 17 out of 20. So the scale goes from -20 to +20. Oops, where are we? -20 to +20, and after the average is 17.7, and before the average was 2.28. So negative is no good. So yeah, -20 is the worst back beliefs, and +20 is the best back beliefs. And yours have gone from average 2.28 to 17.7, which is huge. And for the other, I did a session in Alice Springs, the average was 5 at the start and 15 at the end. So you've pipped Alice Springs. And similarly with Geraldton was 8 and then 17. So kind of similar, big shifts, but not as big as yours. So well done, everyone. Hopefully that means you're paying attention and you've taken some good things out of the session. How long do I spend in each session with each patient? Usually 40 minutes for an initial, if it's just a standard, quote unquote, standard patient. But I like to have an hour for my initials and then half an hour for a follow-up. Yeah, time is one of those interesting constraints. The literature in the randomized control trial in the Lancet, that they had 7 sessions on average with a booster session 3 months later. I think overall we can, it's a tricky, we can talk about funding models and perverse incentives in a fee-for-service type funding model, or just the fact that we often need more time, but we don't get reimbursed for that extra time. There's no funding models that support that, even though on average, this type of intervention, there was a cost effectiveness study or arm of that Restore randomized control trial that showed on average this type of treatment saves the health system $5,000 per patient per year, compared to usual care. So, it's an investment, and I just don't think the funding models have really caught up with that. But super impressed with your improvements in back pain beliefs as a team. Any other final questions? Cool. I might hand back to Taylor.
Yep, that's all good. So we've just gone 10 past 1, so that was great. We love all of the interaction. Thank you, Kevin, so much. Just letting everyone know it was recorded, so if you want to rewatch this or you have colleagues that couldn't attend for whatever reason, I will email out the recording to everyone that registered, and it also goes up on the Rural Health West YouTube as well. So yes, thank you very much, Kevin, and have a good day, everyone.
Thanks, everyone. All the
Bye.
best. See ya.